Thank you, and thank you for that lovely introduction, and thank you very much to Dr. Atlal and Dr. Arti for bringing this all together and bringing us here. We had a very interesting clinic this morning, and hopefully we'll have a very intellectual discussion this afternoon. So my disclosures. So I'm going to be talking about staging of mycosis fungoides and Sézary syndrome, and it's really sort of leaping straight in there because it's quite complicated. So bear with me whilst we go through it. Some of you will be familiar with it. Others, you may be being refreshed because it's something that, unless you're seeing these patients very regularly, it's difficult to remember. The staging, we'll talk about the management guidelines, and then we'll talk about our stage-related therapeutic strategies. So just to remind you, the WHO ERTC classification for cutaneous T-cell lymphomas. And you've got your mycosis fungoides with the variants, folliculotropic, granulomatous slack skin, and pagetoid reticulosis, and Sézary syndrome. And they're the diseases we'll be talking about today. But just to mention, there is a spectrum of primary cutaneous CD30 positive diseases of lymphomas in the skin, which are very different from their systemic counterparts and often have a very good prognosis. And then some more aggressive variants, such as the gamma delta variant. So it's not all mycosis fungoides and Sézary. When we're looking at staging, we have the TNMB classification. And the T stands for the skin, so the tumour burden in the skin, the N node, M metastasis, and B the blood. So how do you test for these stages? Well, the skin is an MSWAT score, so a percentage body surface area of patch, plaque, and tumour. The nodes are assessed using a CT or PET scan and lymph node biopsy if enlarged. And we have an enlargement of 15 millimetres or more as our recommendations for a biopsy. PET or CT scan will also show you any visceral disease, which is very rare at presentation. And blood is determined by flow cytometry, and we use the CD4 positive, 7 negative, and 26 negative population to determine the blood class. So as I mentioned, T is the skin, and you've got T1 to 4, where T1 is patients with patches and plaques less than 10%. Then T2, patches and plaques greater than 10%. T3 is tumours, and T4 denotes erythroderma, which is more than 80% confluent erythema. Nodal involvement, again, we have 4 nodal classes, N0, where there's no palpable lymphadenopathy, or no lymph nodes above 15 on a scan. There's dermatopathic nodes, and these can have a clone, so there can be some atypical cells picked up by TCR, but not visible on the histology. And then N2 with some clusters of atypical cells. And unusually, both N1 and N2 can be seen in early stage disease. N3 pushes a patient into advanced stage disease, and that's where the lymph node has become either partially or fully effaced with atypical lymphocytes. Blood class is B0 to B2, where B0 is less than 250 international units of the aberrant cells that we're looking for, so the CD4 positive, 7 negative, or 26 negative. And sometimes one might be aberrant and the other one may not, so it is worth checking both. So less than 250 puts you into the B0 category. B1 is in between B0 and B2. So if we go to B2, which is Sézary, that's greater than 1,000 international units, and B1 falls in between. And that B2 is important because that's diagnostic of Sézary syndrome, and again pushes a patient into advanced stage disease. So just when you think you've got the TNMB classification in your head, you then have to convert it into the actual stage. And I think this is where it sometimes becomes a little bit confusing. So a table like this is really useful. We have it published in our recent update to the staging and endpoints, which was published in Blood towards the later part of last year, Olsen et al. And what you see is the early stage patients, so that's stages 1A to 2A. And then the advanced stage patients is 2B to 4B. So if we concentrate first on the early stage patients, 1A are patients with less than 10% patches and plaques. They can have low-level blood involvement, but they have no nodal involvement. So N0, but they can have B1. The 1B patients have greater than 10% body surface area patches and plaques. Again, no nodal involvement, but it can have B1. And then finally, the last group in the early stage is the 2A category, and they can have patches and plaques and have N1 or N2 nodes, so can have small clusters of atypical cells in their lymph nodes and B0 or B1 in the blood. So although we refer to these as early stages in primary cutaneous T-cell lymphoma, the disease is not confined to the skin, and that's not surprising because how could you have discordant patches and plaques over the body if the cells weren't traveling in the lymphatics or the bloodstream? So this is just something to remember when we're treating our patients, and one of the reasons why skin-directed therapy can't really offer a cure for our patients, because there'll always be a repertoire of atypical cells elsewhere. The advanced stages, 2B to 4B. So 2B is the tumor stage patients, and then 3A to 4A1 are the erythrodermic patients, and they're separated according to blood class. So 3A patients have B0, 3B, B1, and 4A1 are the Sézary patients, B2. But they're all erythrodermic, and none of them have effaced nodes. They can have low-level blood involvement in 3B and in 4A1, the Sézary blood involvement, but they don't have effaced nodes. If you have effaced nodes, it pushes you to 4A2. And this is an important group, because I'll show you later, this has grave prognostic significance. A patient with partially effaced or effaced lymph nodes has a much worse trajectory. And stage 4B are those who present with visceral disease. So hopefully we can keep some of this in our head as we go through to thinking about our treatments, because they're stage related. Mycosis fungoides literally means the mushroom-like fungal disease, but many patients with early-stage mycosis fungoides never produce tumours and just stay in early stage. Probably around about 60% will always have early-stage disease and will not succumb to their disease. So we must not harm our patients. We must accept that they will have a lot of time spent with their disease in early stage. But the first thing to do is to make the diagnosis. And this can be quite difficult in early stage disease. And we had some conundrums this morning where the diagnosis is not always straightforward. So all of these patients have a scaly rash. Which ones are MF? You can think in your head. All these patients had mycosis fungoides. And the typical histological features, which we'll have a look at in a moment. And these patients were eczema with the typical spongiotic appearance on the biopsy. So what is the histology of early MF? Well, you can get micro abscesses forming here in the epidermis. You have these atypical cells lining up on the between the dermis and the epidermis, and this upper dermal infiltrate with atypical cells, atypical lymphocytes of various sizes, so epidermotropism, microabscesses, basal alignment of the neoplastic lymphocytes, and these cells, these lymphocytes, which don't look small and round like most lymphocytes, but have hyperconvoluted nuclei. And there can be some grandiosity in size, and if you get a lot of large cells, more than 25%, then we call this large cell transformation. And again, it's another very poor prognostic feature, so it's something important to look at in a biopsy. If those cells have changed from medium-sized cerebriform cells to large anaplastic-like looking cells, mutations have happened and often the patient does badly. Unfortunately, we don't always get all those features in a biopsy, and biopsy alone can have a very low pick-up rate for diagnosing mycosis fungoides, and multiple biopsies are needed, as we discussed this morning. As well as the H&E stain, immunohistochemistry, CD3, 4, 8, loss of 7, CD30 positivity, which is often seen aberrantly on the large cells and is now important because of brentuximab and the availability of this monoclonal antibody for treating our patients. T-cell receptor gene analysis is important in early stage disease, but it's not always clonal. If you can find 2 identical clones in 2 different biopsies, and that can help you with the diagnosis. And often you can also see an identical clone in the peripheral blood, even in patients with B0. Close clinical correlation is very important. So don't forget to look at your patient. Don't just look at the biopsy report. Have they got a distribution of patches and plaques in the bathing trunk area? Are they asymmetric? Do they have follicular tropism? Most inflammatory dermatoses are strikingly symmetrical. So the asymmetry in mycosis fungoides, I think, is a very good clinical finding. So what you're sort of hoping for is what we call the full house, and that's when you get the asymmetrical patches and plaques on the skin, the typical H&E findings we talked about with the microabscesses and the dermal infiltrate, which are CD4 positive with loss of CD7. And then a T-cell clone in the blood and in the skin. But not many early-stage patients have a full house. Some of you may have heard of the ProClippi registry. It's an international study. It's an observational study collecting patients throughout the world with mycosis fungoides from diagnosis, which started in 2015. And one of the first things we did was when we started was to go and look at the early stage patients. And when we enrolled them, we asked them how long had they had this type of rash, the MF-like lesions, to try and work out what the delay in diagnosis was. And we found that this was frequently a median delay of 36 months, so 3 years for that patient from onset of MF-like lesions to being told the diagnosis. And that causes a lot of anxiety, concern, and more worryingly, also mistreatments. We know some of the treatments for psoriasis and eczema are not good for our patients, for example, cyclosporin. So actually, not only is it the anxiety of the wrong diagnosis, it can lead to a worse outcome if they get the wrong type of treatments. We talked about it this morning, but frequently, if you're not sure of the diagnosis, if you can't be definite, treat with something that's safe for most things, and that way you don't get caught out. And more importantly, your patient doesn't get negative impact. So just to recap, most patients, about 70% in the early stages, and these are 1A to 2A, with limited patches and plaques. They can have low-level lymph node involvement in 2A, and all of the stages can have B1 blood involvement. So how do you treat patients? Well, you go to our guidelines. We have UK guidelines published in the BAD. The NCN guidelines I'm particularly fond of because they are rewritten every 6 months. So unlike our guidelines, which rapidly become out of date, these are online and they're up to date. Unfortunately, we don't all have as many drugs as they do in the US, but still it's very helpful. And these are our European guidelines in the European Journal of Cancer. The good thing is they all pretty much say the same thing. Early stage disease, treat with skin-directed therapies until the patient is refractory. And they're mainly divided up into those for localized disease, so topical corticosteroids, Ladaga, Togratin gel, radiotherapy, or whole body treatments like phototherapy or total skin electron beam. So early stage skin-directed therapy, but these patients are probably going to have, over half of them will have their disease for 10, 15, 20 years. And it's absolutely acceptable to have many months or years of what we call expectant therapy, and that's no anti-Ctcl therapy, but it doesn't mean do nothing. We can give our patients supportive care, we can give them moisturizers, antipyretics, we can treat infections, pain relief, and give them psychological support. So I think very early on, for a patient with early stage that looks like they have a low-grade patches, poikilodermatous, hypopigmented variant with a very good outcome, they need to be counselled that they won't be free of their disease, and they will have many years on treatment and many years off treatment, but always with some level of disease activity. If they fail skin-directed therapy, what do you do next? Well, you reach into your bag, really, of those other therapies that are available, so bexarotene, interferon, total skin, or any of the therapies for stage 2B patients. So once the skin-directed therapies stop working, it's perfectly acceptable to move on to systemics, even in early stage disease, if the tumour burden is causing significant symptoms or a concern for progression. So this is the study I was talking about, and what we're looking, the Proclippy study, what it was designed to do was to identify prognostic factors in cutaneous lymphoma, so we can try and work out, when we meet a patient, what their likely outcome is going to be, and hopefully thereby learn how to improve the outcome of patients. So we've looked at this in early stage disease to see which patients progress. So with the early stage patients, what clues can we have to know which of our patients who are in front of us are likely to progress? And what we've found is that any lymph node enlargement is associated with a worse outcome and risk of progression. Age greater than 60, unsurprisingly raised serum LDH, plaques, follicular tropism, and large cell transformation. So no great surprises, but useful to know that these are significant poor prognostic variables in early stage. And the plaques particularly are highly significant, so you can see P less than 0.01. And that's true in T1 and T2 disease, so less than 10% and more than 10%. So those patients that have limited plaques have a worse outcome than those with widespread patches. So just something to be aware of. I think widespread patches, particularly of a history of 5 to 10 years, has a very, very good outcome and very, very unlikely to succumb to their disease unless for some reason they become immunosuppressed. So what we see in stage 1A disease is a very good survival. But if you look to 1B disease, already at 3 years, around about 5% mortality. That's 1 in 20 1B patient that you meet won't be alive within 3 years. So it's quite a sobering thought when we think of early stage disease as being a very indolent sort of disease. And if we go to 5 years, 1 in 10 of our patients will have succumbed to their disease. And this is up-to-date data from the Proclippy, which was started in 2015. So we can't say that we're improving survival at the moment. Unfortunately, we're not. Stage 2A disease, 8% have succumbed to the disease within 3 years, and 25%, so 1 in 4 patients who present with early stage disease with nodal enlargement will have succumbed to their disease. So what are the principles of management of early stage disease? Is to improve patients' symptoms and quality of life, to reduce their tumour burden and delay progression. A long survival in early MF with a high symptom burden but occasional disease mortality requires tailored therapeutic strategies. Skin-directed therapy should be considered before systemics. And improving quality of life with symptom control and supportive care should be ongoing through a patient's disease course. So moving on to the advanced management, around about 30% of patients present with advanced stages of disease, which we saw to be the tumours, the erythrodermic variants 3A, 3B, 4A1, and which is the caesary, 4A2, the nodal involvement, or 4B, visceral involvement. Looking at the NCN guidelines, they tend to be listed, as I say here, in no particular order of preference. They're listed here alphabetically. So there's a number of treatments listed for advanced stage disease, but they're not preferenced. So that leaves it up to the physician's experience of using the drugs, the phenotype of the patient. So we have some treatments, for example, like ECP, which we prefer to use in patients with blood involvement, as with mogamulizumab. Obviously, CD30 positivity, we have brentuximab. So we're beginning to select out phenotypes of advanced patients. And I know that Dr. Zane will be talking later about personalized medicine and how we can really help our patients by tailoring the treatment to their disease type. These are our UK guidelines as well, again listed in no particular order of preference. But the one thing I would like to mention, and again we did touch upon it this morning, but maybe didn't dwell on it, is that you can yo-yo with treatments, which is very unusual for most malignancies. So a patient can have, for example, bexarotene, and then they may go on to have brentuximab, and then perhaps they go back to bexarotene. They had an okay, stable disease with it, the burden is reduced, and then they go back on it. So you can reuse phototherapy, you can reuse bexarotene, interferon in different times of the disease. It's not a once you've had that treatment, it's finished. It can come back out. And particularly when there's disease progression, then I'm very reluctant to start it again. But if it's stable disease and the tumor burden is reduced, then it's perfectly acceptable to go back in. Unfortunately, in the UK, we don't have any HDAC inhibitor, so no oral HDACs. We don't have verinostat, and we don't have verinostat, and we don't have depsipeptide, and we don't have ONTAC either. And it's a great problem. Patients have a huge symptom burden, particularly with Sézary syndrome, and we have a slightly different management protocol for patients with Sézary. So in our guidelines, they have a slightly different list of treatments, commonly given ECP first line, sometimes paired with bexarotene and interferon, which we refer to as triple therapy. Methotrexate can be very useful. Usually use it in patients with lower tumor burden. Obviously, we have mogamulizumab for second-line treatment options. Stage 4B is very grave, and really you're trying to salvage the patient. I don't know about Yasmin's experience, but I certainly haven't got many stage 4B patients into any sort of durable remission for a transplant, for example. Nearly there. And the overall stage we talked about. So actually you can see here they mainly cluster apart from this line here, which is your 4A2 disease. And that's significantly worse than the other stages, which are pretty similar survival at 5 years. So, those patients, one, it's prompting us to do a lymph node biopsy, so we know who those patients are, because if we're missing them, we're not doing those patients justice. And if we do find it, then we need to treat them quickly, because you can see that, they have a 50% 5-year survival. A 3-year survival, sorry, and a 25% 5-year survival. Advanced disease doesn't always mean systemic therapy. You can treat isolated tumours with radiotherapy and localised treatments. They don't all need to have systemic therapies. But failure of radiotherapy and multiple tumours, you've got brentuximab, single-agent chemotherapy, either gemcitabine, liposomal doxorubicin, clinical trials, and the PD-1 and PD-L1 inhibitors have been helpful. Brentuximab, anti-CD30, licensed in 2017 for advanced stages of mycosis fungoides with CD30 positivity after failure of one treatment. This was a pivotal trial, the Alcanza trial, which compared it to physician's choice of either methotrexate or bexarotene, and found it was a highly improved response rate with an OR4 of over 50% compared to sort of 15-20% in the physician's choice group. ECP has been a treatment. We'll be talking about this a bit later, and I have a lecture dedicated to ECP, so I won't dwell on it now, but it's very effective for Sézary syndrome and erythrodermic disease. Mogamulizumab, our anti-CCR4, new kid on the block, so to speak, particularly for the erythrodermic variants with blood involvement. It was approved in 2018 for relapsed refractory patients, MF and Sézary, after one systemic. If we do get our patients into durable remission, then hematopoietic stem cell transplantation offers them the best chance of a better outcome, although it's generally not curative, and we tend to have to balance the GVL, graft versus lymphoma, against the GVHD effect, and keep our patients with just low-level, low-grade relapses without them getting their high-grade disease back. We use the Stanford regime, which is total skin electron beam, total nodal irradiation, and ATG. And we have a good outcome in selecting the right patients, but there aren't many patients that we transplant, so it's still a relatively low percentage of our advanced patients. So the principles of management of advanced stage is to improve symptoms and quality of life, to delay progression, and aim for an allo stem cell transplant in first remission of suitable patients. A longer survival in patients with 2B and 3B disease is sometimes seen, so sometimes you don't need to be as aggressive. Consider immunotherapies before chemotherapy. And survival in patients with 4A2 disease, so effacement of their lymph nodes, is short, and they should be considered for stem cell transplant, and this shouldn't be delayed. So thank you for listening. I just want to say there's no right way to treat Ctcl, but there is a wrong way. So don't treat patients with low experience. Don't continue treatments if it's to the detriment of the patient's quality of life. Don't give IV chemotherapy or polychemotherapy in early stage disease. And don't use myeloablative stem cell regimes. And don't perform a stem cell if a patient has a high tumour burden. Thank you very much.